Hello. Today we'll be talking about another case about a patient with schizoaffective disorder. And this case is interesting because it actually is an adverse drug reaction and how to manage an adverse drug reaction, as well as how to manage a treatment resistant patient and some ideas on what we can do for the medication management plan. So let's get into it. AB is a 27-year-old male. He has been admitted to the hospital following striking someone because the voices told him to do it. He presents with symptoms of thought blocking, disorganized thinking, responding to internal stimuli, impaired memory, attention, and concentration abilities. This patient actually, he's slow to respond to conversation. There's a delay. And if he's asked a question, it'll take him 30 seconds or so before he responds to the question. His chief complaint: Aripiprazole was started as an add-on medication because it does not have sedative properties, and he was concerned about not waking up in the morning and hypersomnia. They wanted to start a third antipsychotic for him because he was decompensating from baseline on just two. Recently, after starting Abilify, he began experiencing agitation, increased sexuality, masturbation in the open, and excessive talking. Due to these symptoms being seen closely after the initiation of aripiprazole, we looked into the possibility of this being an adverse drug reaction. So let's look at his medications. He's on lorazepam 2 milligrams and lorazepam 1 milligrams for a total of 3 times a day. And this is for anxiety, and it actually has some other benefits we'll talk about too. His antipsychotics are chlorpromazine, 200 milligrams 3 times a day, Zyprexa 20 milligrams BID 2 times a day, and aripiprazole 10 milligrams in the morning. He's also on valproic acid syrup, 1,250 milligrams at bedtime. So let's look at his psych history. AB has been diagnosed with schizoaffective disorder. This is AB's 4th hospital admission. Mother is very involved in the case. And let me tell you how important family support is. If I didn't have my family or my dad when I went through my psychotic episodes and coming out when I was so depressed I couldn't even get out of bed, if my dad wasn't there for me, I probably would have dropped out of school. I probably wouldn't have a job. I'd be on Social Security, which isn't a bad thing. Disability can be so severe that we need the extra help with government resources. But I definitely wouldn't have had such a positive turnaround if it wasn't for my dad and a strong family support. Patient had chronic mental illness, poor response, treatment resistance, and or side effects to some neuroleptics. Also has episodes of intermittent, unprovoked assaultive behavior in the past. Patient has only had a partial response to medications. The voices never go away but become mumbled on medications. Patient was previously on clozapine but developed neuroleptic malignant syndrome and acute renal failure secondary to clozapine. So I just want to say a couple things about neuroleptic malignant syndrome. Incident ranges from 0.01% to 2.2% of those taking antipsychotics. It can happen with any antipsychotic, including second-generation antipsychotics, but it's mostly seen with first-generation high-potency antipsychotics. It's least likely to happen with clozapine, so it's surprising he developed this while on clozapine. The onset of NMS is 1 to 2 weeks after drug initiation or change in dose. The mortality rate is 12 to 20%. The risk of reoccurrence is actually 30 to 50%, especially if using the same drug. Symptoms include muscular rigidity, hyperthermia, altered mental status, autonomic dysfunction, the respiratory rate goes up, the blood pressure goes out of whack. Hematological changes can occur, increase in leukocytes. Myoglobinuria can occur, which is myoglobin in the urine, which can damage the kidneys. Increase in creatine kinase, which also shows muscle damage, and increase in LFTs, which shows damage to the liver. It's managed with immediate discontinuation of the antipsychotic, and symptoms resolve within 1 to 2 weeks. Pre-NMS dehydration increases mortality, so we see IV fluids given when somebody is having neuroleptic malignant syndrome. We often see patients getting benzodiazepines when they're experiencing NMS because it can help with lethal catatonia and altered mental status. We can also see dopamine agonists such as amantadine or bromocriptine, which can help reverse the dopamine blockade, which they believe is responsible for this, at least partially responsible for this neuroleptic malignant syndrome. So, patient has a history of non-adherence in the community, and I just want to quickly go over his medication regimens at the time of discharge from his previous hospital admissions. Admission number 1, patient was on Seroquel 400 milligrams 3 times a day. He was on chlorpromazine 200 milligrams by mouth in the morning and at 2 p.m. He was on Depakote 500 milligrams twice a day. He was on Ativan 1 milligrams 3 times a day. And he was on lithium 600 milligrams by mouth 2 times a day. It's interesting to use lithium and Depakote at the same time, but we do see it, and it does have the potential for synergistic activity in some patients. In admission number 2, he was continued on lithium, except at a lower dose. He was on Thorazine 200 milligrams 3 times a day, which was a higher dose. He was on clonazepam 1 milligram 3 times a day, and olanzapine 20 milligrams 2 times a day. Admission number 3, he had a similar antipsychotic profile as his other admissions. It looks like they're keeping the patient on Thorazine and switching up between Seroquel and olanzapine, and also keeping the patient on Depakote or lithium. And he's been having a benzodiazepine on his profile. So his current admission, he started on Seroquel 200 milligrams in the morning and 2 p.m. at bedtime. And he was on Depakote syrup 750 milligrams in the morning and 1,000 milligrams at bedtime. However, patient did not want to be on Seroquel anymore because it was painful for his chest. Patient was then started on 20 milligrams a day of olanzapine, and after a couple months was reinitiated on Thorazine. The doses have been titrated up as indicated to improve symptoms to olanzapine 20 milligrams BID and Thorazine 200 milligrams 3 times a day. Aripiprazole was started because it was felt patient would benefit from an additional antipsychotic that was non-sedating and could help with negative symptoms and sedation. The acting psychiatrist felt like patient was decompensating from baseline and would benefit from an extra antipsychotic. All right, so let's look at some objective signs of the patient currently. We have some lab data for him. His serum olanzapine level is 124.4. His valproate level is 74. This includes the valproate that's bound to proteins. And his free valproate, which is the active valproate, is 6.8. His ammonia level is 92. We should always check an ammonia level, especially in patients who are aggressive and on Depakote. Hyperammonemia can occur in 35 to 45% of patients on Depakote. Symptoms can be mild or there can be no symptoms at all. It can include irritability, aggressiveness, and cognitive dysfunction. This occurs because Depakote has a toxic metabolite which interferes with the urea cycle, and Depakote also increases creatine excretion, which again interferes with the urea cycle. If someone has hyperammonemia, we can supplement with lactulose or levocarnitine to reduce ammonia levels. His complete metabolic panel was unremarkable. His CBC was unremarkable. His TSH for testing hypothyroidism is normal. His blood sugar is normal. His parathyroid hormone is normal. His liver is normal. And his B12 and folate level are normal. And his vitamin D is 121. Here are his most recent vital signs. There is nothing really remarkable with these vital signs. So his current mental status, AB is continuing to hear mumbled voices. There's a long delay before he responds to conversation. He has occasional unprovoked violence. He presents with symptoms of thought blocking, disorganized thinking, responding to internal stimuli, impaired memory, attention, and concentration abilities. Patient denies any suicidal or homicidal ideation. All right, let's look at his assessment and plan now. The first problem on his list is we need to explore if aripiprazole is indeed an adverse drug reaction. Patient was recently started on aripiprazole and he began experiencing agitation, increased sexuality, masturbation in the open, and excessive talking. The initiation of aripiprazole was the most recent med change in the patient's medication management. And a little background on aripiprazole is the FDA released a statement that impulse control disorders are reported and can be serious. Pathological gambling is one, but sexual impulsivity is also another impulse control disorder. Patient can be discontinued off medication and symptoms will resolve if it is indeed Abilify. According to prescribing information, aripiprazole showed 19% of patients experienced agitation on the drug, but it wasn't that much different than placebo. Schizophrenia patients can also have agitation, and it may have balanced with aripiprazole. Sudden onset agitation, aggression, impulsivity, and/or changes in behavior could indicate decompensation from baseline mental health. Agitation, aggression, these are positive symptoms and they result from positive symptoms not being under control in schizophrenia. So let's look at possible drug-drug interactions with aripiprazole. Aripiprazole's major metabolic pathway is CYP2D6. Chlorpromazine is a strong CYP2D6 inhibitor, which can cause elevated levels of Abilify. and a pharmacodynamic level, aripiprazole has stronger binding to dopamine 2 receptors than chlorpromazine or olanzapine, and is also a dopamine 2 partial agonist, and is one of the most potent agents to bind to dopamine 2 receptors. And this is important to know because aripiprazole is a dopamine partial agonist. It can interfere with the antagonist properties of chlorpromazine and olanzapine, and the protection that those two drugs were having could be replaced with the aripiprazole partial agonist. So when using aripiprazole in combination with other antipsychotics, aripiprazole can decrease the effectiveness of other antipsychotics potentially. So the plan, I believe it's likely an adverse drug reaction since it was the only recent medication change. Due to patient exhibiting signs and symptoms of decompensation from baseline after the initiation of aripiprazole, it's likely that aripiprazole is responsible for this adverse drug reaction. So it's important that we discontinue the aripiprazole 10 milligrams a day. So what can we do with the patient's other psychiatric management? So patient is on olanzapine. Therapeutic drug monitoring is strongly recommended for olanzapine according to therapeutic drug monitoring guidelines. The target range is 20 to 80 nanograms per milliliter of serum olanzapine. The patient's level is 124.4, so it's exceeding the target range and can increase the risk of side effects. But the benefit of olanzapine is there. It may be a somewhat more efficacious drug than some other second-generation antipsychotics, and patient is on 40 milligrams a day. This isn't unheard of. Olanzapine is often used at doses higher than what the prescribing information suggests, as it often exhibits better efficacy and effectiveness at higher doses. Interesting receptor profile. It indicates that it may improve cognition and negative symptoms, which patient can benefit from since he's having trouble concentrating and focusing. And patient is displaying a few negative symptoms like poverty of speech and thought, lack of social interaction, and blunting effect. But olanzapine can also cause sedation and potentially anticholinergic effects. Patient is currently taking 20 milligrams a day of olanzapine 2 times a day, actually. I should take that out, which is a total of 40 milligrams a day. Olanzapine actually has a half-life elimination of 21 to 54 hours, indicating that it can be given once a day, and it also displays a linear elimination process, which basically means theoretically that if we half the dose, it would half the concentration of olanzapine. Due to this and the half-life, we could potentially give the equivalent dose once a day of olanzapine and have the same steady state as well. A study comparing once a day olanzapine versus twice a day dosing of olanzapine showed that once a day dosing of olanzapine had lower rates of exacerbation of schizophrenia, sleepiness, especially if we take in the evening, orthostatic faintness, and lower mean daily dose. Patient is also on Thorazine. The patient's medication history shows that he has been on Thorazine during all previous hospital admissions. The patient is taking 200 milligrams of Thorazine 3 times a day for a total daily dose of 600 milligrams of Thorazine. There's a study of patients with schizophrenia that they found higher doses of Thorazine are more effective than lower doses. Thorazine is a low potency first generation antipsychotic, so it may require higher doses to see its effect. Thorazine has strong dopamine 2 receptor antagonism, which can help with the patient's continued hearing of mumbled voices. Mumbled voices is better than demands and following the demands from the voices. So he can't understand what the voices are saying right now, even though hearing voices is probably one of the worst things that can happen to a patient. Thorazine poses a high receptor affinity antagonism across dopamine receptors and moderate high affinity at receptors serotonin 6, 7, and serotonin 2, which can contribute to its anxiolytic, antidepressive, and anti-aggressive properties, but can also cause metabolic issues and sedation, and potentially extrapyramidal side effects. So, since patient was decompensating at baseline when he was just on 2 antipsychotics, it was considered to add on a third antipsychotic. So we were trying to decide which antipsychotic would be most beneficial to the patient. And we took in a couple factors. Due to the previous non-adherence out in the community, the patient would potentially benefit from a long-acting injectable formulation. And long-acting injectables show benefits because it has decreased death, rehospitalization, relapse, and suicide in schizophrenia patients. Of the long-acting injectables, Invega Sustenna may be the most appropriate for this patient. This is due to the injection is given once a month. They also have a every 3-month formulation. Paliperidone also has a possible mood stabilizing effect similar to lithium and valproic acid. Paliperidone induces expression of proteins in the prefrontal cortex, which helps with executive function, attention, impulses, rumination, and negative symptoms. But this study wasn't done in human clone cells, it was done in rats. But the paliperidone receptor affinity does indicate that in addition to antipsychotic efficacy, it can be procognitive, antidepressant, and can also improve the quality of sleep. Let me just change that. I tried to read through this before, but sometimes I miss things. Compared to risperidone, paliperidone may cause reduced extrapyramidal symptoms due to its more rapid dissociation from dopamine 2 receptors. Its K-off measurement is about 0.6, while risperidone's K-off is 28. And it also has less metabolic side effects potentially. So that's why I would consider using Invega Sustenna before I would risperidone consta. Paliperidone is also one of the most researched and is probably effective for the reduction of hostility among inpatients with schizophrenia spectrum disorders. In addition, there's less of a concern of drug-drug interactions with paliperidone due to it being primarily eliminated unchanged in the kidney. So for mood stabilization, the patient is also on valproate. Patient is in the target therapeutic range for serum level and also the free valproic acid serum level at current dose. However, he is only taking 1,250 milligrams once a day of depakine at bedtime. Immediate release valproate or depakine is usually given every 6 to 12 hours due to a serum half-life ranging from 6 to 16 hours. So we usually do not see once-a-day dosing with depakine. Labs are drawn in the morning, so the patient could potentially become subtherapeutic before the next dose, especially since his therapeutic levels are kind of in the low end of the target range. The target range for free valproic acid level is 6 to 22, and the target range for serum valproate is 50 to 120. Sometimes patients benefit more from 150 to 160, but that increases the risk of side effects. Valproic acid has linear kinetics, so theoretically the steady state average will be similar if we spread the dose over intervals of every 8 hours or 12 hours if we continue on valproate. Switching to valproex or Depakote delayed release would be more conductive to twice-a-day dosing and would bypass the stomach so the patient does not have gastrointestinal upset. Switching to divalproex extended release will allow once-a-day dosing, but when switching to divalproex extended release, it is recommended to increase the daily dose of divalproex by 20% because the formulations are not bioequivalent. Decreasing the intervals and the dose per interval of valproate will assure the patient is within therapeutic range throughout the day. Clearance of valproate tends to be higher in the evening compared to the morning times. And there is benefit of augmenting antipsychotics with valproate. This combination together showed significantly more improvement in total psychopathology than those treated with antipsychotics alone. And valproate is also used and recommended as adjunctive therapy in patients with chronic aggression and schizophrenia. And the final psychotropic med the patient is on is lorazepam, and continued benzodiazepine because it can help with tardive dystonia of the patient. He has anteriocollis or kyphosis, where it's basically humpback syndrome and is a form of tardive dyskinesia, so lorazepam could potentially help with that. However, there are side effects which include drowsiness, lethargy, and fatigue. It can have long-term effects such as tolerance and potential over-medication from buildup in the fatty tissues can occur over time and have a stacking effect. Lorazepam has less drug-drug interactions compared to some other benzodiazepines due to not having CYP450 metabolism. It would be advantageous if the patient could tolerate a taper of benzodiazepine, but we are trying to reduce the dose of olanzapine potentially because the high serum level, and a benzodiazepine can help with rebound cholinergic symptoms such as agitation and anxiety. So let's look at potential idea of a treatment plan of his psychotropic medication that we can look at based on what we talked about. This is just one of possibly many ideas to help this patient. So because of the high serum level of olanzapine, we could gradually decrease the dose to avoid cholinergic rebound. Since olanzapine has linear kinetics, we could potentially guesstimate what the trough level would be. If it's about 124.4 now, if we decrease the dose by half, it could be 62.2. But it doesn't always work that way, but theoretically we could probably decrease the dose down to 20 milligrams a day and still be in target therapeutic range. But the patient may benefit from a higher therapeutic range or target, but he wouldn't be in the 95% range of patients who benefit from the serum level of 20 to 80. So we can also consider consider changing the olanzapine from twice a day dosing to a higher dose of once a day due to its long half-life and the potential benefits. We can also consider changing the interval and dose per interval of Valprex to allow for less variation in peak to trough Depakote levels and potentially have a steady state average similar to the once a day dosing, but potentially not falling under that target therapeutic range and becoming subtherapeutic. A hypothetical regimen is 750 milligrams of Depakote in the evening and 500 milligrams in the morning of the delayed release tablets, because we did see that Depakote is eliminated and cleared faster in the evening. Patient was decompensating on the current regimen of olanzapine and thorazine before the addition of aripiprazole. This is why it should be considered in trying Invega at a low dose and taper up accordingly. Theoretically, if we see improvement, we can consider tapering down another antipsychotic to establish the least effective dose to maintain patient at baseline. If I had to choose, I would want to taper down chlorpromazine. It may not have the cognitive benefits we see with olanzapine and paliperidone, and together olanzapine and paliperidone will have the same efficacy against hostility as chlorpromazine. In addition, chlorpromazine doesn't have the neuroprotective effects and potential neurogenesis effects of the second generation antipsychotics. So I believe we should always consider second generation antipsychotics over first generation antipsychotics. In general, it would be good to decrease some of the antipsychotics due to the potential of extrapyramidal symptoms, such as the patient having enterocolits. We should probably continue lorazepam because it could help with symptoms of cholinergic rebound from decreasing the olanzapine dosage. It could also potentially help with the tardive dystonia the patient is experiencing. But we can consider decreasing the dose of Ativan in the future, since long-term use can build up in the fatty tissues and have a stacking effect and can cause impaired cognition. Nonpharmacological therapy has a strong role in the outcomes of patients with schizophrenia and their prognosis. The patient currently has strong family support, and I can't highlight enough how important strong family support or friend support or support of the community is in the prognosis of the patient. When I was given antipsychotics, first when I was manic, I ended up in jail. My dad bailed me out of jail because I was trespassing and manic. I felt like I had to be there. And if I didn't get bailed out of jail, I would have stayed in jail and potentially got lost in the system. With the help of my dad, I also was able to get treatment from the hospital. And even during my depressive phases, when I felt like a failure and I wouldn't be able to survive on my own and I'd be homeless, I wouldn't be able to finish college, my dad was there to support me and help me have strength to finish those goals of mine. So strong family support can really help the outcomes of a patient. Psychosocial rehabilitation programs oriented toward improving patients' adaptive functioning are the mainstay of non-drug treatment for schizophrenia. This includes case management, which I had a case manager who helped me fill prescriptions, who helped me get Medicaid insurance, who potentially could help me get Social Security. Psychoeducation is a big part of nonpharmacological therapy. It's important to know about the illness and treating it. And basic living skills, case management can help with basic needs of a patient. They can help the patient, in my case, set up strategies to study or do social activities. There's also psychosocial, cognitive behavioral strategies. There's computer-based cognitive retraining, which helps us focus on the present and things we see instead of what's going on internally. Social media strategies may also be used to improve communications, medication adherence, and potentially detect early warning signs of impending relapse in patients with schizophrenia. I know when I was developing psychosis, I was posting on Facebook, hence I was a genius, weird poetry, conspiracies, and also I was making videos, videotaping things. I was saying clues from the gods, interpreting as different meanings. So while I posted this, my friends, they contacted the police and the police were searching for me. But I was already in jail at the time for trespassing. So work and school programs are another potential tool that can help improve the outcomes of patients with schizophrenia. It can give them meaning, a purpose, and a goal, just like everyone else who derives their purpose from work and school or hobbies. And supported housing and financial support can really help a patient with schizophrenia get on their feet and help them become independent. And then there's the active community treatment, which is an ACT team. It's a 24-hour basis and work in the patient's home and place of employment to provide comprehensive treatment, including medication, crisis intervention, daily living skills, and supported employment and housing. They can even do as little as bringing groceries to your house or checking up on you occasionally. So active community treatment can be a huge asset to patients who are at high risk of relapse or need help living independently in outpatient. And then there's a new target for treatment, and it's the patient's role in recovery-based system of care. The person's lifetime's aspiration and goals become the center of care rather than symptom reduction being the primary focus. So the plan for this patient is to provide patient with opportunities while hospitalized to participate in reprogramming and rehabilitation programs. Upon discharge, help facilitate intensive outpatient treatment to prevent the patient from decompensating and winding back up hospitalized. The final problem on the patient's problem list is urinary incontinence. It has been reported at times that the voices are telling him to urinate on himself. However, his incontinence may be secondary to psychotropic medications. Antipsychotics can increase urgency and frequency, causing urge incontinence, overactive bladder, nocturnal enuresis, nighttime bedwetting, strain to avoid urine, and overflow incontinence. Benzodiazepines and antipsychotics also have weak evidence that they could possibly reduce urethral pressure and cause stress incontinence. Treatment recommends changing or decreasing the dose of antipsychotic pharmacologic treatments and non-pharmacologic approaches as well. It'll be hard to pinpoint which psychotropic medication the patient is on that is actually causing the bedwetting, because there are different mechanisms of the antipsychotics causing incontinence, such as alpha blockade, anti-muscarinic, muscarinic receptor blockade, dopamine blockade. All these can potentially cause incontinence. So the plan is hard to determine what is causing patients' incontinence, and is perhaps a mixture of urge overflow and stress incontinence. We should monitor the effectiveness of oxybutynin, and if there are any side effects from oxybutynin. Oxybutynin can have anticholinergic side effects, which can lead to cognitive issues, constipation, dry mouth, as well as other effects. So we should discuss with the patient the purpose of oxybutynin and whether the patient feels it's helping, if they're having any side effects, and if they want to continue the medication as well, to help us decide if we should continue it. There's also non-pharmacologic approaches like scheduled, using the restroom is one tool. So that about summarizes the ideas for the treatment plan that I had for this patient. Let me know what you possibly think, because there's lots of possibilities for this patient. By no means am I making recommendations for this patient. I'm just coming up with ideas that could potentially benefit patients based on evidence-based research. Each patient is unique, and what I discussed with this patient shouldn't be applied to a different patient. We have to look at each patient individually. I hope you enjoyed this case presentation. It was a long one, but there was lots of material to go over and lots of strategies to think about when deciding what to do with this patient and how to manage their pharmacology. I'll run through this slowly one more time, just in case you want to jot down some ideas or pause the video to hone in on something, or to come up with other information, or to explore any information you found interesting and want to build upon. Hopefully the resource list can help you do that. Anyways, I really appreciate you listening, and I hope you have a good